now we begin the discussion of dermatology. The first thing that we want to discuss are the layers of the skin. So as you know, the lowermost layer which is in connection with the dermis. So we have the epidermis, we have the dermis, and we have the subcutaneous fat. So the lowermost layer is the stratum basale, right? The name itself tells you that it's the basal layer, and the topmost layer is the stratum corneum. Okay, in between there are three layers. So the trick to remember that is legs. Alright, so you want to remember the mnemonic legs, L, G and S. So the next layer here is going to be the stratum lucidum for L. Then the granular layer, you can see there are many granules here, is the layer granulosum. And the thickest layer where you have these spinous processes connecting the different cells is the stratum spinosum. Okay, so these are the layers that we have. So how you remember them? Sometimes you can get a basic question asking you the layers. So you remember corneum at the top, basal, the lowermost, and then you have L, G and S in between. Alright, so lucidum, granulosum and spinosum. Now let's talk about the important cells in each of these layers. So in stratum basale, the two cells that you want to remember are the two M's. So we have the Merkel cell here and we have melanocytes here. Okay, so first, let's talk about the melanocytes. These are the melanocytes which have these dendritic processes. What they do is they have melanosomes which goes to different keratinocytes and supplies them. Now, every melanocyte is going to supply 36 keratinocytes, and that is what is called as the epidermal melanin unit that you see here. So, epidermal melanin unit is 1:36. Alright, that is what you want to remember. 1:36 is the epidermal melanin unit, meaning one melanocyte can give melanosomes to 36 different cells. Then, what you want to know about Merkel cell, it is a sensory receptor and it is the only receptor which is present in the epidermis. Very, very important. Second, it is a slow adapting touch receptor. Alright, so it's a slow adapting touch receptor. And what you want to remember from here is a repeat INICET question which was asked in the form of primary of unknown origin, wherein they had given you the cytokeratin markers. Alright, so remember the cytokeratin marker of Merkel cell per se is CK7 negative and CK20 positive. So this is also something that you see with colon C, and that was the actual question. So remember, colon and Merkel cell actually have the same markers here. So this is just one tangent that you want to remember here itself. Now going on to the stratum spinosum, here the cells that you want to remember are one, the Langerhans cell. So the Langerhans cells are antigen presenting cells. What are their CD markers is also very important. So first you want to remember 207, which is also known as Langerin. This is the protein that is present in these granules. Very, very important image-based question from PATH. This is an image showing you Burbeck granules. These tennis racket-shaped granules are the Burbeck granules, and they have the CD207 positivity. Also, you want to remember CD1A positivity. Alright, so 207 and 1A positivity is what you remember here. Now, this is the thickest layer that I already told you. Alright, and here what you have, why the name spinous is because you have the spinous process, which is nothing but the desmoglein. So we have these desmoglein 1 and 3, and when you have autoantibodies against it, what results is pemphigus. Okay, so this is the desmoglein that is responsible for the spinous processes and the acanthocytes. In granulosum, the name itself tells you that there are granules. So there are two granules that you want to remember. One are the keratohyalin granules. These granules have filaggrin, filament aggregating protein, filaggrin. When this is not there, or there are antibodies against it, or this absence of filaggrin results in ichthyosis. Alright, and the other granules that you want to remember here are the lamellar or the ordoland bodies, and when these are absent, what results is asteatotic eczema. Asteatotic eczema. So you want to remember these two phrases as well. Stratum lucidum is a layer that is only present in palms and soles. Okay, so this is only in palms and soles. Coming to stratum corneum. Stratum corneum has these acellular flattened keratinocytes. So you want to remember the journey of a keratinocyte from the stratum basale to the corneum takes around 28 days, and then to be shed off is another 28 days. So this is what we call as the epidermal turnover time, which is 28 plus 28, that is 56 days. So that is known as the epidermal turnover time, which is 56 days. So you want to remember 36 and 56 together. Now, few definitions. So parakeratosis, hyperkeratosis, orthokeratosis. Parakeratosis means that there is nucleus which is present in the stratum corneum. This is what we see in psoriasis. Hyperkeratosis is the thickened stratum corneum seen in psoriasis again, and now in lichen planus. And orthokeratosis means hyperkeratosis minus parakeratosis. So obviously this is what is seen in lichen planus. Okay. So how to remember this is, orthopedicians are very hyper. Yeah. So you want to remember that they are very hyper, but they are not very pyara. Pyara is para. So this is how you can remember. Orthokeratosis is hyper but not para, which is lichen planus. Alright. So this is about all of the layers of the skin that you want to remember. And with this, we move on to the derma path findings next. Now, with this train of thought only, let's try and finish off derma path from two pathologies, that is psoriasis and lichen planus, because we already know 1 point from each. We know already that in psoriasis, what you have is hyperkeratosis and parakeratosis, meaning there is thickened stratum corneum and there is presence of nuclei within the stratum corneum. In addition, the findings that you see here are two very important microabscesses. So you have these pustules of Kohog and you also have Munro's microabscesses. So here you want to remember Munro's microabscess is present in psoriasis. In addition, I'll give you one more, integrated mnemonic. So through our series of BTR, we're going to be doing a lot of integration between different subjects and different topics. The first one, here you want to remember that P and M are sticking together. Same way, now this is a cross mnemonic. We'll be studying a lot of cross mnemonics as well. So P and M, now you want to remember that you have Potterier's microabscesses in mycosis fungoides. Okay, so mycosis fungoides is going to be Potterier's microabscess. So this is P and M again. Alright, so P and M staying together. Fine. So this is hyperkeratosis, parakeratosis, Munro's microabscesses, Kohog's pustule, and in addition, these are rete ridges, which are elongations of the epidermis in the dermis. These are club shaped or camel foot shaped. Fine. So this is what you want to know about psoriasis. What did we already study about lichen planus? So about lichen planus, we already remember that there is orthokeratosis, and what is orthokeratosis? Remember, they are hyper but they are not para. So this is hyperkeratosis minus parakeratosis. So you can see orthokeratosis here. Now one thing, because psoriasis had both hyper and parakeratosis, we can't give it everything. So what we do is we take away the granular layer. So what you're going to see here is agranulosis. So agranulosis, which is absent granular layer, is a feature of psoriasis because it already has hyper and parakeratosis. But because lichen planus only has hyper, now I got to give it one more hyper thing. So we give it a thickened granular layer. Alright, so this is how you can remember that there is hypergranulosis in lichen planus, and this is actually what is responsible for the Wickham's triad that we are going to be learning in the lesions of the lichen planus. Okay, so this is hypergranulosis. In addition, there is basal cell degeneration. Because the basal cells are degenerating, there is this empty space here, which is called as Max Joseph space, and the apoptotic cells are called as civet or colloid bodies. So this is what you see in lichen planus, Max Joseph space, which is a repeat question. You see civate bodies, which are the apoptotic cells. Fine. So this we have already finished the histopath of two of these diseases, that is psoriasis and lichen planus. Now in this slide, we are talking about 5 annular lesions which are very frequently confused. So the first one that you are seeing here are tender lesions in the shin, which is erythema nodosum. So this is EN or erythema nodosum. Erythema nodosum, one, is associated with drugs. So it is associated with drugs such as sulfa drugs. Then very important, it is associated with sarcoidosis. In fact, there is one syndrome within sarcoidosis which has EN, that is called as Lofgren syndrome. So you want to remember Lofgren has EN in its name. So this is Lofgren syndrome, which has bilateral hilar lymph nodes plus erythema nodosum. In contrast, there is another syndrome in sarcoid which is called as Hereford syndrome. So Hereford syndrome does not include erythema nodosum, it only includes bilateral facial nerve palsy. Fine, so you want to remember Lofgren has EN. Apart from that, inflammatory bowel disease, tuberculosis, another disease which is Behçet's disease, can have erythema nodosum. So erythema nodosum are these tender lesions in the shin, and they represent panniculitis, which is inflammation of the subcutaneous fat. Okay, so this is about EN. Whenever you see the shin, you think EN. Then when we see these very evanescent transient lesions, you have associated history of a cardiac murmur, you have chorea which is associated. What am I talking about? We're talking about erythema marginatum. So this is erythema marginatum, which is an association of acute rheumatic fever. So in acute rheumatic fever, you will have these evanescent skin lesions, which is erythema marginatum. Very, very important, these are two true target lesions, meaning there is a central erythema, a peripheral clearing, and then a border. So when they ask you what are the true target lesions, one, if you see that they are in the hand, they are very, very small, this is erythema multiforme. Small lesions, big name. But when you see a truncal lesion, a big lesion but a small name, erythema migrans. Fine. So this is multiforme and migrans target lesions. Multiforme, very important, is associated with infections such as HSV and mycoplasma. It is associated with drugs such as chloroquine and NSAIDs. Chloroquine is a repeat question, and you also want to remember that chloroquine also produces a target lesion in the fundus. So it also produces bullseye maculopathy. Fine. So this is about chloroquine. Now talking about erythema migrans, very important. It is a cutaneous manifestation, earliest manifestation of Lyme's disease, which we have already talked about in micro. Alright, and then what you see here is a very gyrating sort of a pattern, very hold-like pattern. So this is erythema gyratum ripens. Alright, so this is erythema gyratum ripens, which is a paraneoplastic syndrome. So it is a paraneoplastic syndrome associated with adenoCA, associated with underlying malignancies. Fine. So these are the 5 erythematous lesions that we want to remember. Next, we are talking about papillosquamous disease. We are talking about psoriasis. So the typical hallmark of psoriasis are going to be these erythematous papillosquamous lesions with silvery scales. Very important hallmark, silvery scales. In the nails, the findings that we are going to be seeing, one is irregular pitting. Tell me where we are going to be seeing regular pitting. So regular nail pitting is a feature of alopecia areata. We'll be talking about that. So this is irregular pitting, and the hallmark is this oil drop changes. So there is oil dropping, and there's also subungual hyperkeratosis. Fine. So these are the 3 associated nail changes. In addition, you also have psoriatic arthropathy. So joint disease can also be associated, wherein the most common joint is distal interphalangeal joint. Now, one important test here. So what is being shown is a repeat question. So here, when we scrape off the lesion of psoriasis with a slide, that test is called as the Grattage test. And when you see these particle spots, that is called as Auspitz sign. Alright, so this is called as Auspitz sign, and you also want to remember that there is a Berkeley membrane which is associated. Alright, so there is Berkeley membrane, Auspitz sign, and Grattage test, which are all repeat questions. This is a test of psoriasis, and the most common type in any derma condition, if it's the most common type, it is called as psoriasis vulgaris. Okay, then 2 variants of psoriasis very frequently asked. The one thing, when you see these raindrop-like lesions, they'll give you history of URTI. This is the buzzword here, history of URTI. This type of psoriasis is called as guttate psoriasis. Okay, so this is called as guttate psoriasis, which is associated with URTI, and that is why the drug of choice here is macrolides. Alright, so the only psoriasis where the treatment is macrolides. On the other hand, what you see here is a very pustular kind of a lesion. So this is pustular variant of psoriasis, and here the buzzword that would be given is history of withdrawal of steroids. So this is because of sudden withdrawal of steroids, you will have a precipitation of this. Alright, so that is the buzzword. This is pustular psoriasis, repeat Ames question. And here you also want to remember that if it happens in pregnancy, we call this impetigo herpetiformis. This is very unique to remember for you, and you'll forget it because there is nothing which tells you it is a psoriatic lesion, right? Impetigo herpetiformis. It looks as if it's herpetic, related to herpes, but no. This is pustular psoriasis in pregnancy. It is impetigo herpetiformis. Okay. So now the treatment for this is very important. The drug of choice for pustular psoriasis, remember, is acitretin. Acitretin is a teratogenic drug. Just like we remember isotretinoin for acne treatment, for severe acne, that is also teratogenic. You want to remember 2 timelines here. When a female of reproductive age is on isotretinoin, you want a washout period of at least 1 month before she can become pregnant. But for acitretin, you want a washout period of 3 years before she can become pregnant. Alright, so this is something that has to be taken very cautiously in young reproductive females. Now, because this is something that is teratogenic, it obviously can't be given in pregnancy. So in pregnancy, the drug of choice becomes steroids, and this is very important. Okay, alright, so you remember acitretin and you remember steroids, and you also remember this teratogenic washout period. Okay, so this is about psoriasis. Very important question here about Koebner's phenomenon. So if the lesion increases with trauma, that is called as Koebnerization, also called as isomorphic phenomenon. Isomorphic phenomenon is seen with 3 lesions: L, P, V. LPV, L is LP only, which is lichen planus. P is psoriasis, so psoriasis, the friend of lichen planus comes in, and V for vitiligo. So vitiligo, psoriasis, and lichen planus. 3 things which show Koebnerization. What shows you a pseudo-Koebnerization phenomenon? Meaning it appears as if it is increasing on trauma, but then it's as such only inoculating. So it is viral warts such as HPV, which are auto-inoculation and not true isomorphic phenomenon. And reverse Koebnerization, when the lesion actually heals on trauma, it is also seen in psoriasis. So psoriasis shows you both Koebner and reverse Koebner. Koebner is shown by LPV. This is very important. Okay. Next, we talk about lichen planus. So lichen planus, the lesions are papillosquamous and they are described as these multiple P's. I'm sure you remember that. So they are plain topped, they are purple, they are pruritic, right? So these are the descriptors that the examiner will use. And can you see these whitish stria here? They are the Wickham's striae. Alright, so they are the Wickham's striae that you are seeing here. Okay. Now in the nail, the changes that you are seeing in the nail here is the pterygium formation, and it is also called as pup tenting. So pterygium formation or pup tenting is associated in lichen planus. As far as oral lesions are concerned, very, very important. Remember this approach. Anytime that examiner talks about oral lesion, they mention whether it is wipeable or not. Can it be removed or not? Any lesion that can be removed, you think about candida. Alright, candidiasis oral thrush can be wiped off, can be removed. But when it cannot be removed or it cannot be wiped off, think of two things. One is lichen planus and second is oral hairy leukoplakia. Both of them have an association with a virus. That is how you can remember. So lichen planus is associated with hepatitis C, whereas oral hairy leukoplakia is associated with Epstein-Barr virus. Okay, so this is one common link between them. Both of them can't be removed. One is associated with Hep C, one is associated with EBV. Okay, and also I want to remember that the oral lesions have this lacy sort of a striation. Can you see this lacy pattern? That is how you can know whether it is LP or it's OHL. Okay, so this is your approach independently, very, very important. Next, papillosquamous lesion, which is a repeat question here. You can see how there are these nodular lesions. This is lichen nitidus. So this is lichen nitidus, and this pattern here histopathologically, where it looks like somebody is catching a ball, is called a claw clutching a ball. Quite a tongue twister. So a claw clutching a ball pattern is what is described on lichen nitidus. That is all you gotta know here. Okay. Next, we talk about two lesions, very, very important. So in the first one, you can see how it starts off with a lesion that is called as a herald patch. And this herald patch has these scales which have been described as cigarette paper scales or a collarette of scales. A repeat question. So a cigarette paper or collarette of scales, and then it progresses to form this Christmas tree or this pine tree pattern. So what is this disease? This is pityriasis rosea. It is associated with HHV 6 and 7. You want to remember the scales. This is called as the herald patch, and you want to remember that this is the Christmas tree pattern. So this is the time for integration. Christmas tree pattern, where all is it seen? First thing you want to remember, P rosea. Second thing, Christmas tree cataract. We are going to be seeing in myotonic dystrophy. Apart from that, Christmas tree urinary bladder, we are going to be seeing in neurogenic bladder. We've seen this in radiology as well, right? So these are three important Christmas trees that you want to remember. Apart from that, remember that these lesions are going to spare the palms and soles. And what is the management? So treatment is just conservative. It will go on its own. So just reassure. All right. So very, very important. P rosea. On the other hand, when you see that on the back of the lesion, there are these hypo and hyperpigmented lesions. So variable color, hence the name pityriasis versicolor. They are hypo as well as hyperpigmented lesions. What is the pathophysiology here? It is caused by Malassezia furfur. So it's a fungal infection caused by Malassezia furfur. And very famous question, KOH mount shows you the spaghetti and meatball pattern. So this is the spaghetti and meatball pattern that is seen on KOH mount. And you also want to remember that for SDA culture, we want to add oil here, olive oil, because it is lipophilic, and that shows you a fried egg colonies. And that brings us to another integration for fried egg. So where all have we heard the name fried egg? So one, fried egg, we have seen the colonies in mycoplasma as well. We've seen the fried egg appearance in hairy cell leukemia and also oligodendroglioma, right? So these are four places where we see the fried egg appearance. Okay. Going ahead into infections, very important overlapping topic between surgery, dermat, superficial skin infections. So whenever you see a child and you see this honey crusting, buzzword, honey colored crusting, this is impetigo. The cause, it could be strep or staph. Both of them could be the causes of impetigo. When it becomes like a bulla, then this is bullous impetigo. And what is very important is now the only causative organism can be staph. It cannot be strep because staph has the exfoliative toxin. Fine. You want to remember that staph has the toxin that can produce this versicobullous lesions. And that is why staph can produce what? That is why staph can produce the staphylococcal scalded skin syndrome in infants, which is also called as Ritter's syndrome. Fine. So there are two catch points here. One, staphylococcal scalded skin syndrome has to be distinguished from another syndrome called SJS-10. This is also a condition which produces diffuse cutaneous lesions because of drug. So here the buzzword is going to be drug intake. SJS-10, when less than 10% is involved, it is SJS, but more than 30% is involved, it is 10. So 10 is not 10. Fine. So Stephen-Johnson syndrome, toxic epidermal necrolysis. So less than 10, more than 30%. How to distinguish? There will be oral mucosal involvement here, whereas SSS has no oral mucosal involvement. So this is the first learning point here in staphylococcal scalded skin syndrome. The other catch, Ritter's syndrome versus Ritter's syndrome. So Ritter's is SSSS, whereas Ritter syndrome is something which happens after a pre-existing GI or STD infection, frequently associated with Campylobacter infection or Shigella infection, and you have a triad here. A triad of can't see, can't pee, can't climb a tree. Meaning can't see because there is associated conjunctivitis, can't pee because there is urethritis, and can't climb a tree because there is arthritis. Okay, so this is the triad of Ritter syndrome. And there are two famous questions here, which are the cutaneous lesions. So these lesions are called as keratoderma blenoregicum, whereas these penile lesions are called as cercinate balanitis. Okay, so these are two famous questions, two big names here. Just remember, just hear them once, read them once. I think in the exam you'll be able to identify. All right, so this is Ritter's, whereas Ritter's is staph associated. Fine. So this is about a whole different trajectory that we went on to. Now coming back to the superficial infections, very important. When you see that there is erythematous raised lesions here, this is erysipelas. So this is erysipelas here, whereas when you see that it is ill-defined and it is infiltrating, this is cellulitis. So the presence of well-defined raised lesions is what is going to help you distinguish the two. Alright, so this is erysipelas, whereas this is cellulitis, and so this is the difference between the two lesions. Now talking about three lesions which are associated with hair follicles. So when you have these hair follicle associated lesions, this is the simplest type, which is a folliculitis. Most common cause is staph aureus here. But when you see that there is associated pus collection, this is furuncle. But when you see multiple such collections of pus and it is in the nape of the neck, this is associated with diabetes mellitus. So here you want to imagine an uncle with diabetes and this becomes carbuncle. Alright, so this is a carbuncle. So don't confuse furuncle and carbuncle because both are uncles. You want to remember F and F coming together in a flow, and then you have C as the severity increases. Alright, so this is about follicular lesions. Two lesions which can involve the entire thickness of the skin from the dermis to the subcutaneous fat and also want to involve the muscles. In the groin, this is an image which has been asked so many times in NEET and FMG. This is Fournier's gangrene. Can't get this wrong. Fournier's gangrene is polymicrobial. But is it gas gangrene? No. This we have already done in micro. Gas gangrene is caused by Clostridium perfringens, and only when they mention crepitus on examination or air on imaging is shown on X-ray or CT is shown black hair, only then will you make a diagnosis of gas gangrene. Otherwise, it is Fournier's gangrene. And when you see in a surgical wound, there is this burrowing sort of an orange lesion. This is Melanie's gangrene. So you want to remember here the president of US and his wife, and you want to remember that is a burrowing sort of a lesion. This is Melanie's gangrene. Okay. So this is about the cutaneous lesion. So in this image, you can see that there is an erythematous lesion in the axilla. The hint they will give you here is that there is coral red appearance on Wood's lamp examination. Okay, so this is the hint they'll give, and at this moment I want to tell you what is Wood's lamp. There's a repeat question on this. So Wood's lamp has UVA light which is 365. This number has been asked. Okay, so UVA light at 365 nanometers, and there's a filter which is also a question of barium silicate and nickel oxide. So just keep this in mind. Alright, then we talk about Corynebacterium minutissimum, that is the cause of this infection. So we are talking about erythrasma. So erythrasma involves the axilla, coral red, and Corynebacterium minutissimum. Alright, then when you have these velvety blackish lesions and they give you associated factors such as obesity, there could be PCOD which is associated diabetes mellitus or metabolic syndrome in general, or it could also be a paraneoplastic syndrome because of GI adenocarcinoma. This is acanthosis nigricans. Fine, so this is acanthosis nigricans which is seen here. Then when you have these lesions based around the sweat glands, very important, you have two sweat glands, eccrine and apocrine. Remember, apocrine sweat glands are seen wherever there are hair follicles. So this is seen in A for axilla and groin. Alright, so these are lesions around apocrine and these are your Fox-Fordyce disease. Very important that you remember how it is different from Fordyce spots. So Fordyce spots are seen at the lips. Fine, so these are at the lips, whereas Fox-Fordyce is apocrine sweat glands. And when this becomes complicated with sinuses, this is a repeat image-based question. When there are such sinuses and indurations which are noted here, this is hidradenitis suppurata. So this is hidradenitis suppurata that is noted here. Okay, so these are 5 axillar diseases. Adding to this, one more here, but I want to teach this along with its differential. So there are 2 diseases which occur in the calcium ATPase channels. These are channels which are associated with the desmoglins in the spinous process, in the spinous layer that we had learned, right? So whenever there is a defect in calcium ATPase, it could be in 2A2 or 2C1. When you hear the word C, you want to remember Halley's comet. So this is Halley disease. So Halley's comet, this is C. Whereas when it is A, this is Darier's disease. So Halley disease is also going to involve the axilla with these raised erythematous plaques here, and in the nails you are going to be seeing these longitudinal lines. And also remember, histopath wise there is dilapidated brick wall appearance. Dilapidated brick wall appearance is seen here. Darier's on the other hand, you see these lesions called crop grains and crop rawns. Fine, so these are these raised lesions and there is a V-shaped nail defect that you can see here. Alright, so these are 2 diseases. This is specifically for INI-CET here that you want to remember about this. So I hope the axillary pattern involvement is clear. Now let's go on to the hair follicles and their diseases. So we have scarring alopecia, you have non-scarring alopecia. What you want to remember for the exams here is, in scarring alopecia, there are 3 differentials. You want to remember TLD. TLD is something that we've learned in 2 places. One is a thermoluminescent dosimeter, which is a personal dosimeter that radiologists use for monitoring radiation. Repeat question, thermoluminescent dosimeter. If you remember, in pharma, I've also taught you that whenever there is exposure to HIV, so post-exposure prophylaxis of HIV, now the recent guidelines say 3 drugs, which is TLD drugs. So we have tenofovir, lamivudine and dolutegravir, which have to be given as soon as possible, and it has to be taken for 4 weeks, that is 28 days. So this is where we remember TLD together. Okay, scarring alopecia, 3 diseases. One is tinea capitis. L is lichen planus. Remember lichen planus, purple pruritic Wickham striae because of hypergranulosis, and you had nail changes like pterygium, you had oral lesions which lacy pattern. Fine. And D for DLE, discoid lupus erythematosus. Fine. So these are the differential, and in addition we have learned that in secondary syphilis you can have both scarring and not scarring. Okay, so read the 4 options carefully and mark accordingly. So everything else is non-scarring. So we don't remember that long list. We just remember the 4 things in scarring alopecia, right? When we are talking about tinea capitis, you want to remember 2 different variants, very frequently asked. So either image can be given or descriptors can be given. So when they give you boggy, tender swelling in a child with associated lymph node swelling, we are talking about chirion. And when they say that there are these crustings which are noted, which are called as scutula, this is favus. Alright, the most common cause of chirion is T. mentagrophyte, whereas the most common cause of favus is T. Schonleini. So even if you don't remember the complete names, you want to remember favus has an S, it has scutula and it has Schonleini. Alright, so all of the S's are going to be together here. And one question which has been asked is, which organism gives you a hair perforation test positive? And because we are talking about it, you can remember it right here that T. mentagrophyte gives a positive hair perforation test. Okay, another question which comes here is, what is the drug of choice for tinea capitis? And this is going to be griseofulvin. Very, very important. Everywhere else it's terbinafine, but in tinea capitis it is griseofulvin. Okay, so remember this. Now let's talk about the buzzwords for non-scarring alopecia. If they tell you that it is occurring after 3 months of a stressor, 3 months of a stressor or after pregnancy, but the buzzword is 3 months here, what is this? That is called as tenogen effluvium. Alright, so this is tenogen effluvium, whereas if chemotherapy is the buzzword, it is anagen effluvium. So you want to remember A, B, C, they stick together. So anagen effluvium is what is chemotherapy. If the buzzword here is accessible areas only are showing hair loss, meaning somebody is pulling them, this is an impulse condition called trichotillomania, right? So this is what is called as trichotillomania, and the pattern to diagnose this is going to be the fact that hair loss is only seen in areas which are accessible. Okay, so this is about buzzwords of non-scarring. One very important condition of non-scarring alopecia, they can give you this image wherein there is no inflammation, no scarring, and you can see that histopath-wise there are these lymphocytes near the hair bulbs. This is what is called as a swarm of bees sign. If you examine the hair bulb here, you see the exclamatory sign wherein basically the base or the hair bulb is widened, the shaft is very thin, and then again you have this widening at the distal part. So this is exclamatory hair sign. The nails are going to show you regular pitting. And there is a phenomenon called going white overnight, meaning the patient will tell you that suddenly only white hair are left. So it's not like his hair is turning white, but it's only the white hair which are getting spared. Okay, so that is going white overnight, meaning the white hair are spared by the alopecia. And what we are talking about is alopecia areata, which is an autoimmune condition, and it is associated with diabetes type 1, hypothyroidism because of Hashimoto's, or Sjogren's. So remember these 4 diseases in one breath. They are always associated with one another: Sjogren's, Hashimoto thyroiditis, type 1 diabetes, and alopecia areata. Okay, so this is about alopecia areata. Remember regular pitting, so we did irregular pitting in psoriasis, correct? There are various patterns also in alopecia areata. So if complete scalp hair is gone, this is totalis. If all body hair is gone, it is universalis. Don't mix this two. Total is only scalp, whereas universal is throughout the body. Ophiasis is margin of the scalp, and scypho is basically sparing. S for sparing the side and the back. So these are buzzwords you want to remember. S for sparing, and ophiasis is only along the margin. So this is a potential question. 2 alopecia, which are androgenetic alopecia. So this is because of the male hormone here. It could be male pattern, which is also called as the Hamilton pattern, and you have the female pattern also called as Ludwig's pattern. Also remember Ludwig's angina, which we have done in ENT, when there is floor of mouth polymicrobial infection. Okay, so male pattern, female pattern. As you must be knowing, male pattern is when the frontal hairline recedes, whereas female pattern is going to be the widening of the parting hairline, right? So here parting is widened, whereas here the frontal receding happens. Okay, so this is androgenetic alopecia, and here the treatment of choice is either a topical minoxidil, or you can give finasteride. So what finasteride does is it blocks the synthesis of DHT, right? So dihydrotestosterone is not formed here, and that is why you have reduced AGA. Okay, so this is about alopecia. While we were talking about tinea capitis, let's finish off dermatophytes right here. Rest of it we've all done in dermat, but I wanted to do dermatophytes here. So we have 3 kinds of infections. So we have trichophyton, we have microsporum, and we have epidermophyton. No need to remember complete names, just remember TNNE. So trichophyton, as the name says, 3. It can have all of the layers. It can involve the skin, it can involve the hair, and it can involve the nails as well. In the hair, it involves the shaft from within. So this causes a pattern called endothrix. On the other hand, when you have microsporum, it involves the skin and it involves the hair, and within the hair, it involves the shaft from outside, which is ectothrix. Okay, so endothrix causes a pattern that is called as a black dot, whereas ectothrix produces a pattern called as a grey patch. Now because each shaft is involved from inside, you will see these black dots, whereas because there is diffuse outside involvement in hair loss, you will have a grey patch in ectothrix. Alright. Now in epidermophyton, we have skin, because skin is always involved, and the thing which is left out because hair is done, now we will have nail involvement here. Alright, so these are the layers involved. Next thing you want to remember is what is the difference between micro and macro conidia in each of them. So as far as the macro conidia are concerned, the shape is different. So you want to remember PSC, primary sclerosing cholangitis. So P, S and C. So P is pencil shaped appearance of macroconidia in T, you have spindle shaped appearance of conidia in microsporum, and you have club or cavate shaped appearance of macroconidia in epidermophyton. Alright, so this is macro. As far as microconidia are concerned, you have numerous microconidia here, you have fewer, and you have absent microconidia, so they keep decreasing. Alright, so this is your dermatophytes in a nutshell. Now let's talk about the next group of diseases, which is cutaneous TB, and the most common type in adults. Because most common, so vulgaris, so this is lupus vulgaris, the most common type in adults. And what you see here is central scarring. So central scarring is a feature of lupus vulgaris. In addition, what you want to remember that when I press this with a slide, this is called as a diascopy test. And on diascopy, you're going to have the presence of these apple jelly nodules. There are these apple jelly nodules which are formed at the periphery. Central clearing is what is seen in tinea. So we know it is called as ringworm infection. So tinea capitis throughout the body, tinea cruris along the inguinal folds. What you're going to have is central clearing. So there are these annular ring-like lesions which are active in the periphery. And central crusting, remember, is what is seen in Kala Azar. Kala Azar, cutaneous Kala Azar shows you central crusting. Okay, so remember, scar, TB will always leave scars, so lupus vulgaris. Clearing is tinea because ringworm, you know this, and remaining crusting is Kala Azar. On the other hand, in children, the cutaneous form of TB produces these sinuses which are draining called as scrofuloderma. So scrofuloderma is the most common form of TB in children, and from this only you want to remember another allergic form of tuberculosis is going to be lichen scrofulosorum. So this is an older previous question wherein they asked that all of these are true lichenoid reactions except, and then one of the options was lichen scrofulosorum, and this is not something which is a lichenoid reaction, but it is a tuberculide, meaning it's a hypersensitivity reaction against TB. Okay, so this is why you want to remember this. Okay, next we go on to very important leprosy. This I have combined this from PSM, from Dermat, and this is everything that you need to know about leprosy. Very important, one question always comes from this topic. So now when we talk about leprosy, you got to know that according to Ridley-Joplin classification, there are these 5 types. So I have the tuberculoid pole, and then as we move on, as the immunity worsens and the number of lesions increase from tuberculoid pole, we go to borderline tuberculoid, we go to total borderline lepromatous, and then completely we have the lepromatous pole. As we go from one pole to the other, how do the manifestations change? So the number of lesions will increase. Second, early on in the tuberculoid pole, there will be a single well-defined elevated lesion. Then it becomes completely ill-defined. You can't even make out how many lesions are there. First, it will be a single thickened nerve, and then more nerves are involved bilaterally. Slit smear examination here is negative because here the immunity is very good, but then the immunity worsens, so the number of infective mycobacterium increases on the slit skin smear. Here the lesions are anesthetic, the singular lesions are anesthetic, and then the sensations come, but there is glove and stocking anesthesia is what you want to remember. So peripheral nerves can be involved. Histopathwise, in the tuberculoid pole, what you're going to have, because immunity is present, so you are going to have granulomas forming. But in lepromatous leprosy, very important, you have the zone of clearing that is called as the Grenz zone, and what you see are foamy macrophages. So histopath pattern, very important. When the immunity is good, you have granulomas, but later on you have formation of Grenz zone. Alright. Then we talk about the morphology or the images. So in the exam, you can either get a theoretical question, or more likely they'll give you an image and they'll ask you to diagnose. I'll tell you the buzzwords to identify which would be mentioned. So in the tuberculoid type, what you're going to have is a single raised lesion with associated nerve thickening. So they can give you that there is a nerve which is thickened here, there is a single lesion which is raised. In the borderline tuberculoid, you want to remember 2 things. You want to remember that there are satellite lesions. This is last year question. Satellite lesions. Can you see these lesions at the periphery? Satellite lesions, and then can be associated nerve abscesses. So what you want to remember here is Santa Banta. So Santa Banta is the trick. So SN, so Santa, and BT for Banta, right? So that is how you can remember. Then in the borderline, so this is the one which gets asked most frequently. In fact, if you get a question on this and if you're not sure, you go ahead and mark BB. BB has a variety of names. So the names which have been described for borderline lesions are annular, inverted saucer appearance. It has been called as a punched out lesion, right? So this is your borderline variant. Then as we go to borderline lepromatous, the number further increases. They start to become more ill-defined. And lepromatous is where the number could be in hundreds and then you would not be able to discern them, right? So they become indiscernible as the number increases, alright? So the trick here is first to rule out whether it is Santa Banta, otherwise it is BB. Fine. So this is about leprosy. Now let's do a few one-liners from leprosy right here. So what is the route of infection? Remember, it is inhalational. It is not via cutaneous touch, it is inhalational. The virulence factor is PGL1, phenol glycolic lipid 1. Just want to remember this. Most common cranial nerve is the 7th nerve, and because 7th nerve supplies the eye, orbicularis oculi doesn't work, and the complication could be exposure keratitis, which is the most common cause of blindness in leprosy. Very important. Most common nerve for biopsy, this has been asked last year in NEET exam, this is radial cutaneous nerve. If this is not in the option, then you mark sural nerve, but first is radial cutaneous, which was asked, and the earliest sensation lost is temperature, particularly cold temperature is lost early, and this is very ironical because leprosy loves to involve the colder areas. That is why the peripheral nerves, the pinna, are the most common preferred sites because they are cooler, alright? So that's how you can also remember this. Now we talk about the different variants of leprosy from where you can get questions. First, you want to remember indeterminate type. Indeterminate type, here you will have a child with hypopigmented lesions on the face, and you want to remember that there are going to be sensations which are reduced or lost, because the biggest differential here is going to be pityriasis alba. Pityriasis alba will also have child with face lesions which are hypopigmented, but they are going to be itchy and they have scales, whereas here you are going to have sensation which is reduced. Next form is the histoid type, wherein you have nodules. This is a type of lepromatous leprosy where lesions are not flat but they are nodules. Lucio leprosy is what is called as a pretty face. Lucio means very pretty in Mexican, and here in lepromatous leprosy, because there is this diffuse erythematous lesion, the face appears very, very shiny because of the involvement of the sweat glands. You have this appearance called Lucio leprosy, and Lazarine leprosy is what is associated with malnourished patients, patients with HIV who have nodulo-ulcerative lesions, alright. So these are the variants that you want to remember for leprosy, okay. So this is in a nutshell the important stuff you want to know about leprosy. Now let's bring in PSM right here. So for operational definition, what you want to remember is that we have divided leprosy treatment into paucibacillary and multibacillary, because it's not possible for workers at the periphery to diagnose the exact type, isn't it? So what we are doing is we have divided into a very simplistic operational definition. You diagnose whether it's PBL or it's MBL, and then we treat accordingly. So if the skin lesions are 0 to 5, this is the most important. If 0 to 5 skin lesions, it is paucibacillary. If more than 5, multibacillary. If 0 to 1 nerve involvement, PBL. If more than 1 nerve involvement, multibacillary. If skin slit smear is negative, it is PBL. If it is positive, it is multibacillary, right? As simple as that. So how does the treatment change? Now according to WHO, now we are following a uniform MDT. Earlier there used to be different drugs for PBL, MBL, but now it's the same, just the timeline varies. So a PBL person has to take the pack for 6 months, whereas a multibacillary person has to take it for 12 months. Alright, so this is what you want to remember now. We follow the WHO uniform treatment. It is still not accepted in the National Leprosy Guidelines as far as India is concerned, but then you still want to remember for the exams that this is what is being followed now. So what does that include? All of these patients are getting these 3 drugs, which is RDC. So rifampicin, first of all, it's the most effective drug against leprosy, is 600 mg once a month supervised, meaning this is also a type of DOTS regimen wherein the patient comes to you once a month. Once a month patient comes to you, you give him rifampicin 600 mg, then and there it's done. Dapsone he has to take daily, so 100 mg OD he has to take, and clofazimine is both. So clofazimine you give him 300 mg once a month supervised when he comes to you, and 50 mg he has to take on a daily basis. So how you remember is 600 and 100, and then you half both of them, so it becomes 350. Okay, so this is something you want to remember the doses for. We also have different blister packs. So this is what India currently follows, wherein there are different packs for paucibacillary and multibacillary. So just remember the colors. For multibacillary, which is now going to be followed for everybody, it's a pink pack, whereas paucibacillary was a green pack. For a child, it is blue and brown. So now with the upcoming guidelines, this is the only thing that will now be used. Okay. Now talking about the lepra reactions, very, very important. So we have type 1 and type 2 lepra reactions. Hypersensitivity type, extremely important, easy to remember that the sum total should be 5. So type 1 lepra reaction is actually a type 4 hypersensitivity, whereas type 2 lepra reaction is a type 3 hypersensitivity. So basically the total has to add up to 5, as easy as that. Type one is what is seen in the borderline type. So borderline tuberculoid or borderline lepromatous, and it is seen within 12 months of treatment. So there is relation to treatment. Whereas in type 2, it is seen in the lepromatous pole when the immunity starts to improve and there is no relation to treatment here. Here, the pre-existing lesions, very important. This is the buzzword, that pre-existing lesions become raised, they become tender, alright. Whereas, so here you can see how the pre-existing lesions are becoming raised and tender. Whereas in type 2, which is also called as erythema nodosum lepra, what we will have are new lesions. So we have new nodular lesions which are associated in type 2, and there is associated systemic involvement in type 2, which could be because of fever, there could be arthralgia, there could be the presence of orchitis as well. Okay. Treatment wise, very, very important that if they ask you the first line in type 1, it is NSAIDs. What is the drug of choice? It is steroids. Same with type 2. What is the drug of choice? It is steroids. First line is also steroids here. But if asked most effective, it is thalidomide. So this is much like what I've taught you in radiology for cholecystitis. What is the investigation of choice? It's ultrasound. But what is the gold standard? What is the most accurate? It is HEDA scan. So technically it is far better, but it is not used because it has a lot of side effects. There's a lot of radiation. Same with thalidomide. So many side effects, particularly flipper baby phocomelia. We don't want to use it, but it is overall the best. Alright, so you want to read the question carefully. Drug of choice is steroids, and one important thing, do you stop the leprosy treatment? No. So you continue the leprosy treatment. Alright, so you continue your multi-drug therapy. This is always going to be in the option that you stop MDT, you do not stop it. Fine. So this is about lepra reactions. So now we're going to be talking about STI, sexually transmitted infections, and this is one of the most important topics for all the exams, FMG, NEET and INI-CT, and you get short questions from this, and there have been certain exams where you get 3-4 questions from this topic, because this comes in dermat, this comes in gynae, this comes in PSM as kits, so I'm going to integrate all of it and bring it in one place. So do this from here and it's done. Fine. So we are going to be taking an approach which is going to follow the syndromic approach that the kits follow, and we take it from there clinically. Okay. So here the color coding of kits is also very important. So now I've seen lots of mnemonics for these. Alright. So now what we're going to do is forget all of these mnemonics. So there's more brain space which is created, and when I say that, you are like, great, no more mnemonics. Okay. So the first kit we remember is where we say great. So from great we remember that the kit 1 is going to be gray in color. Another great thing about it is that it can treat 3 different pathologies. It can treat urethritis, which is urethral discharge, cervical discharge, which is cervicitis, and painful scrotal swelling. Okay, so 3 conditions can be treated by the same kit. So again we go great. Now what the causative organisms are for urethritis, cervicitis and painful scrotal swelling are the same. So we have gonorrhea and we have chlamydia. These are the 2 most common organisms. Okay, so now the fact here is, how do you distinguish which infection is there clinically? A separate question if you want to distinguish, how do we do that? So when you make a smear of the cervical discharge and you find that there are WBCs and you find intracellular diplococci, that finding is going to be suggestive of gonococci. But when there are only WBCs without any diplococci, that is chlamydia. If asked what is the investigation of choice, you say it is NAAT, nucleic acid amplification test. Fine. Now remember, as far as treatment is concerned, we never treat one of them alone. They always are treated together. Even if you prove it is gonorrhea, you got to treat for chlamydia because coexistent infection is very common. So drug of choice for gonorrhea is cefixime. Drug of choice for chlamydia is azithromycin. So what we do in the kit is combine them. So we are giving azithral 1 gram stat and we are giving cefixime 400 mg OD stat. You want to remember these drugs. And because it is a stat treatment, the patient takes these drugs and he is done. So that is why patient also goes great. Alright, so you want to remember gray kit is great, 3 things, no mnemonics and 2 drugs treated, gonorrhea and chlamydia at the same time. So azithral and cefixime. Okay, so this takes care of urethritis, cervicitis group for us. Next we go into the group of vaginal discharge. Here you want to remember Rachel Green. From Friends, you know Rachel Green. So Rachel Green is a female and now I've spoiled Rachel Green forever, and you want to remember green kit is for vaginal discharge. Okay, so here first I'm going to teach you the approach. How do you approach a case of vaginal discharge? Three differential diagnoses. Before we go into the pathologies, one repeat question is when they asked you that a young female presents with vaginal discharge around mid-cycle, around 14th day of her cycle, and she has having no malodor, it's just physiological discharge. So remember, before you go into pathology, rule out physiological discharge because that is a repeat question. Not all vaginal discharge is pathological. If it occurs around the mid-cycle, around the ovulation, and there is no malodor, that is physiological. Okay. Now coming on to the main stuff, which is pathological. If they give you that there is thin off-white discharge with a fishy odor, the buzzword here is going to be the fact that there's fishy odor without much inflammation, and there are these clue cells on a smear, which are these epithelial cells with these rod-like bacilli coating it. The pH is alkaline, and if you add KOH, there is a amine odor, and that is called as a whiff test. Very, very important. So there is a positive whiff test. Another question here is Amsel's criteria is what is used for bacterial vaginosis. Amsel's criteria is used for this, and what we are talking about is bacterial vaginosis, and it is caused by Gardnerella vaginalis. The drug of choice is metronidazole. Next is trichomoniasis. The buzzword is there is associated inflammation. So there is yellow-green discharge, inflammation, and that is why you have strawberry cervix, strawberry vagina here because of the associated cervical and vaginal inflammation. Again, the pH is abnormal, and what you would see are these trichomonads. We've already discussed this in micro that the trophozoites here are going to have a single nucleus, and there are 4 flagella here and then 1 flagella anterior, so total 5. You remember the auntie here. So this is trichomonas. Again, the drug of choice is metronidazole. Talking about candida. So candida all C's here. So you have cottage cheese, curdy sort of a discharge here, and you have pseudohyphane. This is the only infection wherein the pH is normal. So you want to remember that there is acidic pH here, which is normal in candida. Everywhere else it has increased. And fungal infection, so drug of choice is fluconazole. So the approach, 3 buzzwords. If it is a fishy odor, clue cells, whiff test, or Amsel's criteria words are mentioned, it is bacterial vaginosis. It is not an itis, it is not inflammatory in nature. This is caused by Gardnerella. Then we have strawberry cervix, strawberry vagina. You have a trophozoite, which is same. We are talking about trichomoniasis. Both of them, metrogyl is the drug of choice. When we talk about candida, curdy, cottage cheese discharge, normal pH, fluconazole. So now you got the idea that we got to treat with metrogyl and fluconazole to take care of everything. Because metrogyl is a longer treatment, we replace it with secnidazole in the kit. So secnidazole 2 gram OD stat and fluconazole 150 mg OD stat and stat treatment, and we are done with vaginitis and its clinical approach as well, which gets you sure short questions. Now we go on to the approach to ulcers, and then we look at the kits. So whenever you are dealing with a case of genital ulcers, you always have to approach it with painful ulcer or painless ulcer. If it is painful ulcer, there are 2 differentials. If it is not ulcer per se, but the examiner is mentioning vesicles or erosions which are red. So remember red, this is erythematous vesicles and erosions, and I'll tell you why I'm stressing on red in a minute. So this is vesicle and erosion, and the diagnosis is herpes simplex, and this is going to be HSV2. Remember, STIs below the belt is HSV2, above it is HSV1. So herpes labialis is HSV1. Encephalitis is HSV1. Okay, so this is herpes simplex virus 2. Another painful lesions, it makes you cry. So this is Haemophilus ducreyi. You remember cry, and this is chancroid. So H. ducreyi, chancroid causes painful ulcers. Alright, so painful, look if it's vesicle, it's HSV, otherwise it's chancroid. If it is painless, look at the morphology of the ulcer. If the ulcer is having this hard indurated base, and you are having lymph nodes also which are very painful, very rubbery, we are talking about chancre, primary chancre caused by syphilis. On the other hand, if it's a beefy red, exactly opposite, beefy red granulomatous sort of an ulcer, we are talking about donovenosis, also called as granuloma inguinale, and this is caused by Calymatobacter or Klebsiella granulomatosis. Alright, so you want to remember granuloma here, and this organism is going to have this safety pin appearance. This is called as the bipolar safety pin appearance of Calymatobacter or Klebsiella is what you're going to be seeing. If the ulcer is painless and it is transient, in fact you don't even see the ulcer anymore, all you see are these lymph nodes which are called as buboes. So you're seeing these buboes, which are these enlarged inguinal lymph nodes. They could be seen above and below the inguinal ligament, and this is what is called as the groove sign. So inguinal buboes have this groove sign, and the cause here is going to be chlamydia. Chlamydia has this lymphogranuloma venereum strain. So this is lymphogranuloma venereum. You have L1, L2 and L3 serovars, and L2 serovar is the most common cause. So this is buboes or lymphogranuloma venereum caused by chlamydia. So this is about your approach. Painful, it could be HSV or chancroid. Painless, if it's hard, it is syphilis. If it's beefy, it's granuloma inguinal. If no ulcer, only lymph node, it is bubo. Got this? Now how do we treat? So here we categorize. Obviously viral, it's treated differently. So this is erythematous, so it is treated with a red kit which has acyclovir. Then we have buboes, which is a different category. Buboes is B, it is treated with a black kit. Remaining we have 3. We have to deal with chancroid, chancre and donovanosis. Interestingly, chancroid, donovanosis, the drug of choice is azithromycin. So syphilis is a disease wherein we use penicillin for treatment. So we have penicillin here and we have azithral, which we are going to treat separately. So this is how we categorize the treatment so that it is, compartmentalized in your mind, and it's very, very easy. You don't need any mnemonics. So now when it's a non-herpetic ulcer, we have our kit number 3 and 4. So 3 is the kit which I will use for my middle category. So I'm using benzathine penicillin 2.4 million units, 1 vial IM injection stat, and we give azithral 1 gram stat. So kit 3 is white, it is peace, you have no problem, everything is done stat. Now if you have hypersensitivity, if you are allergic to penicillin, then you become cyanosed. So that is how you remember. Blue kit if there is allergy to penicillin. In that case, I replace it with doxy. But now it's not stat. It is doxy 100 mg BD for 15 days and we give azithral as it is. So you just want to remember that from penicillin I have switched to doxycycline here. Blue because cyanosed for allergy. So that's done. So we're done with kit 3 and we're done with kit 4. Kit 5, if you remember, herpetic ulcers, red. So this is your red kit with acyclovir, which is also not stat treatment. So acyclovir 400 mg TDS for 7 days. Let's deal with buboes also. So buboes is kit number 7, B for black. And you also want to remember buboes are bad. So bad is bubo, azithral and doxy. So the kit 7 contains azithral and doxy. Azithral is same 1 gram OD stat, but doxy now instead of 15 days that we saw with syphilis, it's now 21 days. So 100 mg BD for 21 days. Here the dose was same, but it's 15. Now we've increased 1 week, it becomes 21 days. The last kit we want to remember is lower abdominal pain. So from low you remember yellow, and this is for PID, lower abdominal pain, meaning there is pelvic inflammatory disease, and here you want to remember dilated cardiomyopathy, DCM. So DCM you want to remember doxycycline 100 mg BD, again the same dose for 14 days. So this is like syphilis, 100 mg BD for 14 days. C for cefixime 400 mg stat, same dose, and metrogylis 400 mg BD for 14 days. So this is going to be DCM for yellow. So I hope kits are now imprinted in your mind. That's the aim. Let's go through it one more time. 3 pathologies treated with the first kit, which is grey kit, cervicitis, urethritis, scrotal swelling. We gave 2 drugs, which was azithral 1 gram and cefixime 400 mg. Then we went on to Rachel green for vaginal discharge. We gave secnidazole 2 gram and we gave fluconazole, correct? Then we approached the genital ulcers. We categorized into 3 things. The middle category where I want to treat syphilis and I want to treat chancroid and granuloma inguinal. So I give azithral and I give penicillin. That's kit 3, which is white kit. Then if there is allergy, we become blue. So in blue kit, if you have allergy, we replace penicillin with doxy for 15 days. Then we went on to herpetic kit, which is red, so that is acyclovir. Then we had buboes. Buboes are bad, kit 7 black, which was azithral and doxy. And then in the middle we had our last kit, which was low for yellow, which was for PID, and PID is DCM, dilated cardiomyopathy. So doxy, cefixime and metrogyl. Yeah, so did we need any mnemonics? No, so that is great. Alright, so this is about STIs in general, and let's just finish it from path as well. So in the pap smears, they can show you these images of infections. So when you see that there are these kite-shaped organisms, these are nothing but the trophozoites of trichomonas. So this is your trichomoniasis, which is seen on a pap smear. When you see that there is this shish kebab-like effect, wherein you can see that the cells are arranged on this string. The string is nothing but the pseudo-hyphae of Candida. So this sign is called as the shish kebab sign, wherein it looks like they are on a string. So this is Candida. This you already know it from the image. When the cells are coated by these tiny bacilli, this is bacterial vaginosis. And what you see here is this cotton ball. All of the organisms are clumping here. This is the cotton ball effect, which is seen with actinomyces. So this is seen with actinomyces, and remember actinomyces, we've done this in micro. Is this acid fast? No. A, no. So this is acid fast, no. This is anaerobic, so this is A, no, right? So you remember anaerobic, non-acid fast, and here you have history that there is associated copper T or IUD usage, right? Intrauterine contraceptive device usage. Okay, so this is about actinomyces. Now we go on to the next category, which is bullous diseases. First, I'll tell you a broad categorization. When do they occur? As we discussed in the stratum spinosum, the thickest layer, there were the spinous processes. So here we have either epidermal bullous diseases or we have dermal diseases. So when it is epidermal, because the roof is thinner, because the split is within the epidermis, they are going to be these flaccid bullae. They are going to be this flaccid bullae which will rupture very easily. If desmoglein 1 is involved, which is 1 is higher, so here the split is going to be subcorneal, just below the stratum corneum there is a split. So subcorneal split, whereas DSG3 is going to be suprabasal. So this is just above the basal layer. So subcorneal, suprabasal. Another way of asking is the layer. So this is very simple. What is the layer below the corneum? So this is going to be granulosum, right? Because lucidum is not present everywhere, it's only in palms and soles. But if they ask you the layer here, suprabasal, it is spinosum layer, right? So this is how the question could be framed. Don't get confused. If one thing you want to remember 1 is subcorneal, upper, and 3 is niche, which is suprabasal. Alright, desmoglein 1, if it is involved, this is going to be seen in pemphigus foliaceus. The prototype here is P. foliaceus, another DD could be P. erythematosus. Because it is much more superior, remember that these are very, very flaccid. They don't even present as bullae, they present as erosions. And here there is no oral involvement. The prototype for DSG3 is the most common pemphigus, which is pemphigus vulgaris, hence the name P. vulgaris, and the variant P. vegetans. So both of the V's are going to be here, vulgaris and vegetans, and most common is pemphigus vulgaris, which has a suprabasal split. And you also want to remember that there is oral lesions here. Alright, very, very important. Dermal split is because of dermal antigen. So here I am showing you this image of the basement membrane zone. Can you see the BP antigen here, bullous pemphigoid antigen? That is what is involved in dermal, where you have antibodies against them. So this is BP antigen which is involved, and this is bullous pemphigoid, which are these tense bullae, because there is a roof which is intact. Alright. In addition, there are other dermo-epidermal lesions which I will talk about, but the prototype is bullous pemphigoid. One special category is mechanobullous disease. Just remember the name. If there is bullous disease with trauma, the diagnosis is epidermolysis bullosa. Just remember EB, epidermolysis bullosa. It can be congenita or acquired acquisita. Alright, so this is epidermolysis bullosa. Epidermolysis bullosa, remember, has 3 types. The congenital type, it can be simplex, where there is keratin 514 involved. It could be junctional, wherein you have laminin which is involved, and in dystrophic you have absent type 7 collagen. The most important antigen you want to remember is type 7 collagen. Why? Because both of these, the type 7 collagen and bullous pemphigoid, are going to be tense bullae. How do you distinguish? So this is Ames special, INICT special, where we do a special immunofluorescence called salt split immunofluorescence. If the split is in the roof, meaning the antigen involved is higher placed, that is bullous pemphigoid. But if it is in the floor, that is epidermolysis bullosa acquisita, or basically the congenital type, that is dystrophica. So acquisita or dystrophica, meaning type 7 collagen is involved. So don't get confused here. One trick to remember this, salt split immunofluorescence is being talked about in the question. Roof is BP. You can remember it as a trick that BP is something that we drink on the roof. Fine. So I think that is something that can help sort this complicated topic. Now let's see the images. So the first group we are discussing is the pemphigus group, meaning that here it's an intraepidermal lesion. Okay, so pemphigus vulgaris is the prototype. So you're gonna have these flaccid bullae which are very easily ruptured. You have a Nikolsky sign which is positive in pemphigus but negative in bullous pemphigoid, meaning if you apply tangential pressure to them, they are gonna rupture. Okay, so this is the prototype of pemphigus. If you see oral lesions, oral ulcers are present, then I know that it is P. vulgaris and it can't be P. foliaceus. Then if you do an immunofluorescence, very important, because it's intraepidermal, we are going to have this fishnet pattern, very, very important, fishnet pattern wherein you have IgG and C3 continuously getting deposited. And when you see the split, can you see how these are the basal layer? It's a supra-basal split, and that is how I know that it is P. vulgaris or P. vegetans, but P. vulgaris is more common. So this is supra-basal split, and this is also called as a row of tombstone appearance. Okay, so this is your row of tombstone appearance that you can see here. Fine, so this is about pemphigus. Now let's talk about the three diseases in the dermo-epidermal junction. The prototype here is bullous pemphigoid, BP. Bullous pemphigoid, as I said, is going to have these tense bullae. And there is also pruritus which is associated, because if you do the histopaths, there is going to be presence of eosinophils, alright, not neutrophils, eosinophils. If you do the immunofluorescence, you are going to have the deposition of IgG and C3 along the dermo-epidermal junction against BP antigen, right? So this is all the points you need to know about bullous pemphigoid. Then what we see here is this linear deposition. When we see what is the deposition, it is IgA. So this is linear IgA disease. But they will not ask you that which disease shows a linear IgA deposition. And the answer would be linear IgA. That's not how easy life is. So the other name you got to remember for this disease, which is chronic bullous disease of childhood. CBDC, chronic bullous disease of childhood. Fine. The kind of lesions that you're going to see here are going to be perioral perigenital. This is called as a string of pearls appearance. And one association I want you to make here, if they give you a child with such lesions which are perioral perigenital, also think of zinc deficiency, and that is called as acrodermatitis enteropathica, because you will also have associated diarrhea. Okay, so this is one association for you to remember. So this is linear IgA disease, chronic bullous disease of childhood, string of pearls appearance, and whenever Ig is deposited, drug of choice is dapsone, whereas for pemphigus and bullous pemphigoid, it is a steroid pulse treatment that you give. You can also give cyclophosphamide, alright. Now comes the most important part, where they give you on the extensor surface, there are these pruritic lesions, erythematous lesions. This is dermatitis herpetiformis. Now, neither is this a dermatitis nor is this a herpetic lesion, but the name is because there are clustered erythematous lesions which are vesicles, and there is pruritus, hence the name, but it is basically the cutaneous manifestation of celiac disease. Very, very important. Immunofluorescence is very important. You're going to have this granular deposition, and this pattern is called as picket fence appearance. This picket fence granular appearance, wherein you have the deposition of IgA at the dermal papillae. Alright, so this is IgA deposition in a picket fence manner. If you see the histopath here, you're going to have neutrophils which are present. Okay, so I told you eosinophils are present in BP. Neutrophils, or these papillary micro abscesses, are what are noted here in dermatitis herpetiformis. Remaining things about celiac we have discussed in GI also. Okay, so just to recap, remember, so brow is to be avoided here. What is brow? Barley, rye, oat and wheat. These are the four things to be avoided in the diet. And what is the drug of choice? Again, it is dapsone. So the trick is, wherever IgA gets deposited, drug of choice is going to be dapsone. Okay, so this is about the vesico-bullous diseases. Next we go on to the pigmentation disorders. So here I'm going to teach you the approach. So first we can have epidermal pigmentation, or we can have dermal pigmentation. So epidermal pigmentation is something which is going to be brown in color, whereas dermal pigmentation is going to be slate gray or blue in color. This is because of the Tyndall effect, alright, that is the one thing you want to remember. If we do a Woods lamp examination, remember Woods lamp, UVA of 365 nanometer. If we do a Woods lamp, there is going to be accentuation here, but no accentuation on Woods lamp here. That's the difference. In fact, because it is blue, this is also called as Cerebelloderma, and one drug which causes this, which is a repeat question, it is amiodarone, right? So amiodarone causes dermal pigmentation, that is Cerebelloderma. Fine. Now we talk about three conditions which show you epidermal pigmentation. If this is the image wherein you have it around the face, this is called as mask of pregnancy. This is melasma or cloasma, which is associated with pregnancy or OCPs. If you see that the nose is showing pigmentation and they give you history of joint pain, they give you history that there is retroorbital pain with fever, think of chikungunya with hyperpigmentation. This is a repeat question, and this is called as the chick sign. The chick sign of chikungunya. If you have a patch at the shoulder with associated hair, this is the Becker's nevus. So this is the Becker's nevus. Now dermal pigmentation, if it's an infant with this lumbosacral pigmentation, these are Mongolian spots. Just reassure the parents that it's going to resolve by 2 years of age on its own. If it is in the orbit, this is nevus of aorta. So you remember O for orbit. If it is at the scapula, it is nevus of Ito. So how not to confuse this? Aorta is O for orbit, whereas bricks are carried on the shoulder. So eat, so you remember shoulder. Fine. So nevus of Ito is on the shoulder. So this is about the diagnosis here. So this was about the hyperpigmentation disorders. Now we discuss hypopigmentation disorders. Alright. So here in the first image, what we are seeing is this area of depigmentation or hypopigmentation, which is called as nevus anemicus. Now this is a misnomer because neither is this a nevus nor is there anemia here. This is actually a problem with vasoconstriction. There is excessive vasoconstriction which happens in certain areas because of a problem with the alpha receptors that results into this abnormality. Now what we are seeing here is this typical white forelock. Whenever you see white forelock, there are two patterns that come into mind. If you can see that there are these islands of depigmentation along with sparing, so when the word is islands of sparing, this is known as piebaldism. So this is piebaldism, which is a defect of melanocytes. Alright, so melanocytes origin from neural crest cells, so there's also a problem with neural crest cell migration, just how we have Hirschsprung disease, right? So even the parasympathetic ganglia that we have, the plexus of the intestine is also derived from neural crest, so that's also a migration problem. Alright, so that's a correlation for you there. Apart from that, if they give you, in addition to white forelock, there is presence of heterochromia iridis, the iris is of different pigments or different colors, then what you have to rule out here is a syndrome, that is Waardenburg syndrome. Alright, so this is Waardenburg syndrome. Now when it occurs because of some sort of chemical, it is known as contact leukoderma. Alright, so this is what is known as contact leukoderma. So here you can see this typical pattern of slippers which results in rubber slippers. So this is because of the presence of hydroquinone here. So this is because of rubber. Then what you can see here is because of the bindi adhesive that females use in our country. You can have this depigmentation, which is para-butyl phenol, which is seen in bindi adhesives, which is also a repeat question. And you can also have this in hair dyes, like whenever you're dyeing your hair, first you need to bleach it. So that is para-butyl catechol. Alright, so this is about contact leukoderma. So these are the important hypopigmentation disorders that we need to know about. Now two patterns, very important. In the first image, you can see how the nasolabial folds are involved. There's an erythematous rash involving the cheeks and the nose, and the nasolabial folds are involved, whereas here you have this area being involved, but the nasolabial folds are spared. So this is what is the typical appearance of the malar or the butterfly rash of the SLE. So this is SLE, whereas if it is involved, this is what is rosacea. So this pattern here is rosacea that you want to remember, where the nasolabial folds are involved. They'll give you history of triggers here, that it gets triggered. There are these telangiectasias which happen. There's this flushing which happens anytime the person is emotional, or there is spicy food, or there is hot weather. So triggers would be mentioned here in rosacea. Fine. Now talking about ichthyosis. So when you see this fishnet pattern over the limbs, this is the most common type. This is ichthyosis vulgaris. I have already told you that this is because of antibody against filaggrin. Correct? So this is ichthyosis vulgaris. If they give you this history, this is last year NEET question, wherein a baby is born with a membrane. This is called as a colloidal baby, and this type of ichthyosis, which eventually the membrane sheds off and you have this fishnet lesions which are seen in the trunk. What is this? This is called as lamellar ichthyosis. Fine. So this is lamellar ichthyosis. Another ichthyosis wherein you are going to have fishnet pattern on the trunks, that is X-linked ichthyosis. So this is something that you can confuse. So remember, if it is on the limbs, it is ichthyosis vulgaris. If it is on the trunks, only X-linked, but trunks with this membrane history which was asked, it is lamellar ichthyosis. Fine. One independent image which can be asked to you, what is this? So this is the patch test that is done for allergic contact dermatitis. So this is done for allergic contact dermatitis. One very important allergen is nickel that is present in artificial jewelry, right? So this is read at what time is a question. So this here is read at 48 hours. And if it's not present, at 96 hours. Alright, so this timeline has been asked. So remember 48 and 96 hours. Next slide is for malignancies that we want to remember. So when you see this lesion here, red lesion with these raised pearly nodules, this here is the most common malignancy, cutaneous malignancy, which is basal cell carcinoma, has a very good prognosis. And this image has been asked of histopath, wherein you see this true palisading and you see the cells in a layer. This is what is called as a true palisading. Okay, so this is basal cell carcinoma. Next malignancy, I've already talked to you about it. Where do we see Potrier's microabscess? So you remember PM, Munro's microabscess in psoriasis, Potrier's microabscess in mycosis fungoides. Okay, so this is mycosis fungoides, and what you also see here are these lymphocytes which are going towards the epidermis. So this is what is called as epidermotropism, and this is nothing but cutaneous T-cell lymphoma. Cutaneous T-cell lymphoma, if you look at the cells individually, they have a nucleus which is a cerebriform nucleus. So the word cerebriform we will also read in the stomach as far as Menetrier's disease is concerned. We will also read a cerebriform nasal or a paranasal sinus mass, which is basically inverted papilloma. Okay, inverted papilloma, Menetrier's, and cutaneous T-cell lymphoma or mycosis fungoides. When this becomes hematologic, alright, so when this goes into the bloodstream, it's no longer cutaneous, then we call it Sézary syndrome. Then we call it the Sézary syndrome. Okay, so this is about that. Then talking about melanoma, so remember they can show you an image of a melanocytic nevus and they can ask you what's the complication. So that's an easy question. It turns into melanoma, and the signs that it's turning malignant is A, B, C, D, E. They can ask you these individually and one of the options can be wrong. So A is asymmetric. If the margins of the nevus become asymmetrical, if the borders become uneven, or there are multiple colors which are developing, diameter is important. This number is important. It becomes greater than 6 millimeter, or it is evolving, meaning it's changing its size and shape. So A, B, C, D, E, asymmetry, borders, color, diameter, and evolving. Remember this full form. And also they ask you what is the most important prognostic factor. It is the depth, which is the Breslow's depth. Alright, so remember most important is the depth of involvement, that is called as Breslow's depth in melanoma. Okay. Now, two particular things I want to tell you. What you are seeing here is a horn. So this is what is called as a cutaneous horn that is seen in actinic keratosis. Actinic keratosis is something which is a pre-malignant condition that can turn into squamous cell carcinoma. On the other hand, when you see this kind of a stuck-on, that is the buzzword that would be mentioned, this stuck-on kind of brownish appearance. So when you see this stuck-on appearance, this is seborrheic keratosis, and this could be seen in underlying malignancy. So this is also paraneoplastic condition when you have multiple lesions. This is called as sign of lesser Trellat. So multiple seborrheic keratosis can be present, sign of lesser Trellat, and that is something which is a paraneoplastic syndrome, but overall it is not pre-malignant. So you want to remember that S cannot turn into S, and it is A, it can turn into S. Alright, so this is seborrheic keratosis and actinic keratosis, very easily confused, so I've just put them together. Next we talk about the cutaneous syndrome. So neurocutaneous syndromes, first one, when you see these macules which are brownish, hyperpigmented, these are café au lait macules. So these are café au lait macules which are the hallmark of neurofibromatosis 1, and you want to remember NF1 is autosomal dominant, chromosome 17 neurofibromin. In contrast, NF2 you will have 2 for 22, it is also autosomal dominant. All neurocutaneous syndromes are autosomal dominant except Sturge-Weber. Talk about Sturge-Weber, wherein you will have a port wine stain on the face and you will have tram tract calcification of the skull, that is sporadic. So you want to remember that Sturge-Weber is S for sporadic, every other neurocutaneous is going to be autosomal dominant. When you see these two lesions, so you are seeing that there are nodular lesions on the face. This is adenoma sebaceum, and associated hypopigmented macules. These are ash leaf macules on the trunk. We are talking about tuberous sclerosis, chromosome 9 and 16. Remember, hamartin, tuberin, alphabetical order. Hamartin and tuberin, you will have hamartomas formation. So you can have subependymal nodules which lead to seizures. You can have angiomyolipoma in the kidney here, right? Very, very important question. A fat containing black mass in the kidney on CT, it's angiomyolipoma. If you see that there is violet lesions around the orbit, this is what is called as the heliotrope rash, and on the knuckles you have these Gottron papules. It's a repeat question. What is the pathognomic feature of dermatomyositis? It is Gottron papules. So this is dermatomyositis, which is also associated with underlying malignancy. So this could be paraneoplastic. There are antibodies which are anti-MI2 antibodies and anti-Jo1 antibody, which is also now called anti-synthetase antibody, and there is a new syndrome called anti-synthetase syndrome, but you just want to remember in the options MI2 and Jo1 are associated with dermatomyositis. In addition, you can also have an erythematous rash around the neck, which is called as the shawl sign here. Alright, so this takes care of derma for us. So this is the end of derma in around 2 hours. So this is how we're going to be doing the rapid revision of all